Everybody.
Hey Beth, good afternoon, everyone.
Awesome. We'll give everybody just a minute or so to get in. Brenda, I don't know if you're seeing anybody else in the waiting room.
Not at the moment.
Okay, cool. Well, I thought we first would maybe give Corey an opportunity to introduce himself as he joins us for the first time from NAMD. Corey.
Well, thank you so much, and good afternoon, everyone. My name is Corey Caldwell, and I'm a senior policy analyst with the National Association of Medicaid Directors. I'm going to be taking the place of my colleague Lindsay Browning, who I believe served on this panel last year. So very excited to get to be here with all of you today.
Yeah, great. Thanks for joining, Corey. Okay, well, let's just jump in and get started. Next slide, please, Sam. So, admin items and meeting objectives, CMMP activities, feedback, poll, and wrap up. So, we're going to do the things a little bit different this time around. We've been talking for a little while now about how we feel like these meetings tend to be more report out to you all and not conversation. And we definitely want to make this more conversation driven and get your feedback and get your thoughts about what's happening, in the MCHB space in general, but then what's happening with our stack, and any challenges we potentially are having, getting your feedback from that. So we're going to structure this just a little bit differently. This time you all should have gotten a read ahead, which hopefully you've had a chance to read ahead on, that brings you up to speed on where we are with the stack, this first year stack, what they're working on, what their objectives are, and the things that they've been thinking about and focusing on. And then we'd like to have some conversation, around some specific questions for you all regarding what these teams are working on. Next slide, please, Sam. Um, Afterwards, we will definitely ask you to fill out a poll for us. This is a different kind of structure that we're working on. One I hope yields, more conversation and it is a little bit more meaningful and fruitful. But if it's not, we definitely want to know that. So definitely fill out the uh, the poll for us at the end. So with that, Helen, any HRSA updates or anything you think that I've missed or you want to jump into? I can tell you that uh, Erin Patton is back as uh, our project officer, which is wonderful. Great to see. We are working on our year 2 stack applications that is in the field right now. We have close to 50 opens on that application and no completes yet. But yeah, thanks, Erin. And feel free to pop in and say hi. Um, we have no completes yet. The application is due January 30. Um, but we're excited about the at least the open rate with almost 50 opens. So some of those are states that have opened more than once, and we know that. But at least they're looking at the application, so that's exciting. We are also planning and starting to plan our first cohort annual convening. Each cohort will come together one time in person, and that we are looking at some dates now at the end of April mid-May to bring that cohort together for its annual meeting. I think that's pretty much it for HRSA, for updates. Erin, anything you want to add?
No, just a quick hello to everyone. Good to see you all. Thank you, Beth. Yeah, excited for how things are moving forward with this project, and looking forward to hearing you guys' feedback and input as well. So just thank you. And I'm probably going to be off camera most of the time. I just got out of a block grant review, so it's just been a long day on camera. So, but thank
Yeah,
you.
for sure. Totally understand. Totally understand. Thanks, Erin. Um, with that, I think, Helen, unless you have anything to add, we could jump into the next slide.
Nope, nothing to add. Let's go ahead and jump in.
Perfect. Um, so I'm actually looking at a different slide deck, Sam.
Interesting. Hold on one sec.
That,
Let me take a look at that. One second.
and I'm happy to share mine, um,
Hmm.
really quickly.
Sure. Why don't you do that? Because I thought I had pulled up the right one and I'm not sure what happened.
No problem.
Yeah, I think the version Beth had might have just had a couple notes on the stack activities by the states and territories themselves so that we could have that for reference. But Sam, if you also have the sort of the questions from the pre-read at hand too, so those are useful as well. We can kind of keep those on hand as well, also to kind of help guide us. But I'll keep those on the side of our desk, and I can even, you know, put them into the chat too to help guide us as we go. However, we do, any questions, any thoughts are welcome. These are really just sort of guiding framework questions to get us started. But we can absolutely sort of go off the slide that Beth will have to share to or has to share that frames some of the activities.
So can you see my slide?
I'm not, but are you able to share? We might need to make sure that you have
Sharing
ability.
capability.
Yep. Let's make sure.
Yep.
Now it looks like it's
Okay.
loading.
All right.
Yep, there we go. Seeing it now.
Perfect. Wonderful. So, this is just a really high level kind of reminder of what was in the read ahead that you guys all took a look at, um, and of where the stack activities are. So I first, I've got some guiding questions for us, but um, specifically want to kind of go through some of where the states are, and ask some specific questions. So I want to start with Indiana. Indiana is a interesting state for us because they are trying to build that relationship and that partnership with their Medicaid agency. And so, Jamie and Marcus, I really kind of want to pick your brain to, Marcus, I know you and Iowa have just a really robust, meaningful relationship between your Title V and your Medicaid agency. Are there selling points that you guys use between Title V and Medicaid to help kind of make this value proposition on how your teams should come together and why your team should come together, and anything that you guys did to kind of create that relationship that we may not have been talking with Indiana about yet, or would be good food for thought for them. Anything, Jamie and Marcus, that you guys have in this space would be amazing to share.
And Kimberly too. I saw her join, although
Yeah, yeah,
she might have dropped.
yeah. I did see her flash through too. And really anyone, but I'm thinking about, Jamie and Marcus for sure.
Yeah, for Iowa, I mean, ours is really long standing. I mean, before I was Title V director, we have had this strong relationship with Medicaid. So I've just continued to foster those relationships. We've had turnover in staff. So like once we got sort of replacement from Sally, who was there for like 30 years, like I have new people, but it's again fostering those relationships with those people and having that sort of point of contact. Like it's a person. So it's not that I just contact Medicaid and be like, I need to talk to somebody about this topic. Like we have a long like a relationship with, now it's Becky. So she's sort of our person. So like having that like individual that like we always go to instead of it just being a like who at Medicaid can help Title V do this, I think has been really beneficial. I also always go back to the like law that they have to work with us, so I don't let them off the hook when they don't want to. So I'm like, you realize that you're like required to have this relationship with us. So I think sometimes just reminding them of that helps too.
Yeah. Yeah.
And my apologies, I'm having a little bit of trouble with my sound because I'm in a public place, but do you mind just restating the question?
Yeah, no problem, Jamie, at all. Just wondering, with Indiana being trying to establish that relationship, if you have any kind of um, food for thought for us, any tidbits, any kind of things that you think we should pass through to Indiana to say, here's how you can start to establish this relationship between Title V and Medicaid.
Yeah, I mean, I would really just reiterate what Marcus said in terms of having a point of contact on each side. I think that makes a big difference rather than this general expectation that the two entities need to collaborate. It's sort of having that champion within the Title V organizational structure and the Medicaid structure that I have, at least in my experience, has really helped to kind of move things along.
Yeah. Did you guys have to make like a value proposition to the other agencies to be able to like convince them that, yeah, well, sure, it's the law, right? We have to work together, we have to have a relationship. But was there beyond that? Did you have to come together with numbers, data, something, or was it more softer than that? Was it people bound? Was it story bound? Did you guys do anything like that?
I know back when like the relationship started, Medicaid came to us because they were in trouble. So they were at their screening rates were at 8%. So 8% of Medicaid kids were getting in for a well visit. And so they saw the value of like public health, this more population-based work that we could do to help get kids into care. And now like we're up over 80% meeting the federal requirement. So I think part of that was like them understanding that we're not always just that like individual client base, that we can provide that population base. And that's what I keep talking with them now with the new sort of staff is like, here are the things we can offer you to help either provide input to your, based on the clients that we're serving, or like the outreach and education that we can provide to providers and to
Into
the general
the general.
population. So I think those are the things like helping them understand that we're not just likely not service providers on that sort of individual basis, but Title V is that like the bottom layer of the pyramid and how we can support them in those ways.
Yeah.
Yeah, and I would just say what was helpful in particular in Arizona was for us to have those champions, but then to have the two entities sit down together and really work through, I think, a thoughtful kind of SWOT analysis process where
Mhm.
we're giving some background on each of our agencies, what we each bring to the table, but then being really honest, frankly, about where we're struggling. And to Marcus's point, on the Medicaid side of things, there's a lot of pressure, understandably, and it's important to attend to performance on some of those key quality metrics, and that's where public health can be so valuable. And when we come together, we can have strategies that complement one another from that sort of collective impact model. But for us, it was about identifying those champions, coming together and having a conversation about what we each bring to the table and where our needs were, and then really documenting a plan going forward in terms of how we would collaborate. So we had it on paper and that served really as a point of reference for both agencies. And um, we didn't do this to the degree that we needed to, but I think, developing some concrete timelines too, in terms of that collaborative effort can be really helpful.
Oh, that's great. That's great. Brina, I know you have some comments.
Well, I'm typing away, but I'll just say that, and I'm so glad Corey's here. I was taught by a Medicaid director years ago that we at Title V needed to recognize Medicaid as a program, not a payer. And
Mhm.
that when you go toward them as with all that Title V has to offer in community relationships, medical provider connections, and that you're in service of Medicaid's goals and outcomes, it's a just a strength-based relationship. Marcus said the same thing. And then just the funny part that I forget what you said your person's name is. Our person in Vermont's name is Ashley. And the first time we met her, she was pregnant, so we got lucky in that front because she was about to come into our world, and she's since had two children. So the sort of personal reminder, we just had a lot of graphics about what is title. Title V just doesn't have any communication power when you talk about it in that weird, wonky way. So we had these cool, glossy, you know, sort of strategic plans that took the measures, the national and state measures, and put them in a way that was easy to digest. And we brought them over to Medicaid and said, "Isn't it weird? You guys are working on some stuff, and so are we. It's almost the same stuff, and really, we really want to help you." So it's
Yeah.
essentially what everyone else was saying. Yeah.
No, that's great, Brina. Jamie, go ahead.
I just wanted to reiterate something that Jeff put in the chat, the importance of executive level endorsement of collaboration across the entities. Whenever I think we were interested in really pursuing an initiative or some sort of collaborative effort, we found it to be really beneficial to go to, in my case, the governor's office and have them really push the two agencies to come together.
That's great. That's great. Jeff, I'm wondering if you might be able to talk a little bit more about how you think we could help Indiana get that level of support or get that.
So I always think about how we can change the minds or their priorities because everybody's busy and they're doing good things, but talking to each other is not the first thing on their mind. So
Yeah.
one of the things I think is, and I wanted to do this with our CMC center, but we haven't done it yet, is go to states and actually assess the levels of collaboration at the levels of supported, the collaboration at different levels. Because, you know, in a different project where we're talking about combining public health and Medicaid data, the states that have been successful have had somebody at the governor's office or in the legislature say to them, in 6 months, I want you to come back with a plan of how you're doing this, what your staffing needs are, and what your barriers are. Because I think that's how you get, this done. And I added something to the end of that because it's like the commissioner may not think about that because they're really worried about work requirements right now or whatever they're worried about. So you have to put some pressure on them sometimes by, by going through the governor's office or having families go to legislators, et cetera. But I think that's the way I don't think you can drive this change by just doing it at the staff or even the managerial level, because inevitably those staff and managers have other things on their plates. And unless somebody says to them, I need you to do this by Tuesday,
Yeah.
it won't get done.
Yeah. That's interesting. Alex, I see your comment in there too. Do you have any ideas on how we would get that kind of executive leadership involved?
Yeah, I think just wanted to kind of echo what Jeff said in the chat as well. Yeah, I think, we've seen just making sure there are folks who kind of have a longer tenure, as mentioned, and maybe staying on beyond just gubernatorial, elections and different administrations. Those folks can tend to be champions of the partnerships and may have existing relationships that are longer term and able to be sustainable again across various leadership changes. So I think I saw maybe in the notes one of the states had included a chief medical officer or maybe a deputy. So I think involving those folks could be a really helpful way. I know we've seen a lot of strong partnerships between public health, chief medical officers, and Medicaid. And there's sometimes some overlap and with oversight in that position as well in some states. Yeah.
Yeah, that's interesting because I think we've had a lot of conversation about trying to ingrain this as a culture and that it survives then that turnover and that churn that can sometimes happen down at the lower levels. And so that's really interesting. Yeah, Jamie, go ahead.
I was just gonna mention the importance of external stakeholders and advocacy organizations in terms of influencing leaders to make this sort of collaborative effort a priority. The example I'll give in Arizona, we had a really strong organization representing children called the Children's Action Alliance. And, they were very influential with executives in the state. And there were times when I would have a conversation with them saying, hey, can you help me? Partner with me in appealing to state level leaders to make this a priority. And that was really successful.
It's great. Marcus.
I was just also going to add, I think, Title V in general has had a lot of push and work around the IIA, making sure it's part of our application and we talk about it during our reviews and making sure that it's reviewed. I think there is still opportunity on sort of the Medicaid side. I know they have, like Jeff said, there's a lot of things going on right now in the Medicaid world, but like reminding somehow continuing to educate them like about this IAA, why it's important, like why Title V and Title 19 work together. And, I think that sometimes Medicaid is so big that this is just one tiny little piece of the Medicaid program and it's not always pushed like it is on the Title V side. So that's one thing I brought up. I think when the center first got set up and there was a listening session at AmChip, I think the conference or the partnership meeting or somewhere. And I was like, making sure that CMS is up at the table, making sure that there are those opportunities for education at the Medicaid directors meeting or at other Medicaid meetings about the relationship between Title V and Title 19, because I still think like the push is still on the Title V side to really make a lot of this work happen, because it is such a priority of Title V, where like making sure that that's happening on the Medicaid side of things as well. So
Yeah, that's a good point. That's a great point. Any other thoughts on this topic before I kind of move us to another thing? These are all great thoughts.
Yeah, I was just gonna, Paige had a comment in the chat too that kind of echoed the statute behind what Marcus was saying too, is that, a lot of the education need behind that too, Marcus, is on both sides too, that the fact that the CFR that exists to sort of outline those requirements is within the Medicaid side. It's within the Title 19 is where that requirement sort of lives. And so it really is, it lives within the requirement of Medicaid to initiate the agreement. And so it's how to, lean on that to kind of build that awareness, build that understanding. And so that is something that like we need to come to this table together because this is a requirement of both of us and sort of serves both of us to it. I do want to just like see if there's anything that Lauren might want to say from a comment earlier that actually may have come, we might have circled back to, as she said in the chat, to like flesh out sort of more conversation around MOUs. And Lauren, please feel free to say that like, nothing more really is applicable, but anything else that you would add to the IAA conversation here?
Yeah, I think we touched on a lot of it already. But I think also Jeff made a really great note on a lot of what I was talking about, of having something that's structured, built out, kind of pieced into the infrastructure of what you're planning, and have that two-way conversation of hey, we can offer this for you to support you, but we are not just trying to either give one way or get one way, because a lot of the times I feel like they're like, well, what, you're wanting something from us and this is why you're coming to us. and to say, yeah, but we can support you in these ways too. So kind of navigating what that conversation looks like, having those meetings to work through that together. And I think an MOU exercise is a really great way and pretty standardized way of doing that. And then having it sit in there that in a way that's accountable, especially when a lot of us are, seeing a lot of, as we mentioned before, like staff turnover and things like that. So it's easier to bring onboarding too, of saying, hey, here's our partnership with them. Here are the types of things that we've said that we can support them on. So we want you to be mindful of that when we're working with this partner and things like that.
Mm-hmm.
That's great. Thanks, Lauren. So I want to jump to Louisiana. Jamie, you touched on this a little bit on bringing in those families and the voices of the folks who benefit. Louisiana is looking to align and define their medical advisory committee, their advisory committee or councils, their MACs and their BACs, and they're exploring with us how they can leverage the Title V experience and how Title V works with families and community engagement. I want to know from Shonda and Naomi and Jamie and Marcus and everyone on the call really, from your experiences, what are a good way to engage? What are good engagement strategies? Like, what can we tell Louisiana to be thinking about foundationally as they set this work up? How they can work with the Title V agencies, utilizing their F2F chapters, whatever it may be. Are there things that you guys have all seen that work really well when you're trying to engage families and communities in your work? And I'll start with Shonda and Naomi. If you guys have any, or maybe even better, please don't do this. Mm,
I think
Mm-hmm.
is it Brina? She puts a good point in. They have to have adequate reimbursement for family representative time. I think it sends a message as well as the importance of having family representative embedded. I would also say here in Washington State, I live rural. I live in a really rural pocket of the state that has a lot of indigenous and tribal communities, and listening sessions and hearing and making the effort to go there, not just have, Zoom is great. It's a great way to connect because our geography is so big, but to establish real relationship for sustainability and partnership, those pocket communities really need to be massaged and fostered to be able to get the authentic needs of what's happening. And then out of there, you typically will find some folks that want to step forward and be leaders in their community. But that's the experience that I've had with where we're at here in Washington.
that's great. That's great. Any other, Brina, any other to-dos or Christina or Alex or anyone on
Yeah,
family engagement?
I think there's tons of experience on this call. This is really hard to do well. You need commitment. It's not fair to like to bring a family into a meeting without a lot of prep and then just say, "What do you think?" or "Here's a document for you to, quickly review." I've heard people describe it that we're asking families to join our system, which isn't, it's already like a mysterious, just the way we're talking to each other about Medicaid, not understand, imagine being a family. So the times I've seen it go well, there's a lot of prep and there's a meeting ahead of time with family representative to explain like what is it a Medicaid advisory committee or what is a beneficiary, and try to jargon bust the thing so that when the person is actually in the decision-making meeting or in the advisory role, they feel that there's like equity, like that there's been some. And then really, if you're going to do it well, you would then debrief as well. You'd have an opportunity to meet after to say what was that meeting like for you, and what, is your role clear, and was it the right place to use your expertise?
Hmm, that's great. Kimberly, I see your comment in the chat here. Can you say more about how you guys employ your families and is there any lessons that you learned that you would tell Louisiana, don't do this?
Um, I mean, I would say that we have kind of tried everything and it does kind of ebb and flow. Like some of the folks on here had mentioned. The thing that has worked best is to have families appointed on a 2-year term so that we have commitment. We've also incorporated guidelines, not necessarily bylaws, but guidelines that establishes some parameters so that they know the expectations going in on how many meetings they should be attending, how many meetings we're expecting to have throughout the year, the timings of those meetings, and then we do have one larger meeting every year that also includes the medical advisory committee so that they know that there's going to be at least one meeting per year that they're going to be at the table with some physicians, and that can be a little scary, but that they have an equal place at that table. So I think just open communication on what you need from the group and what they expect to get out of it, I think is really important.
That's great. That's great. And establishing those expectations kind of written down, right? Like they have that in front of them. Um, Christina, I want to come to your comment in the chat too, um, and how you work with the Title V SHIN programs and how closely they work with the F2Fs in their states. Um, any lessons learned you've got there?
No, I think I was just saying that it's really helpful to work with like a family-based organization to kind of strategize and
Yeah.
engage families. And I think there are several Title V SHIN programs that do this. I do think um, SHIN programs work really closely with families on a lot of different areas. So I think, connecting with the SHIN Title V programs directly, um, having Medicaid do that would be helpful. And then also, it's so important to also um, meet with the F2F and strategize with the F2F or other family-based organization in the state to kind of make sure families are prepared and have those leadership skills and then can go in there and attend those meetings and engage in the conversations and everything.
Yeah, that's great. Heather, I wanna turn it to you. You put in a toolkit from Kansas. Can you say a little bit more about that?
Sure. Um, so I guess full disclosure, I was part of creating this when I was at the States. So certainly maybe a little biased, but what I loved about what was created was really it was built by the Family Advisory Council members. And so we spent about a year and a half working with them in different ways to capture these various tools, really thinking about how the state Title V program could really partner with the families in a variety of different ways. So at various levels of engagement. So there's components in here about, engaging with families from an input, gathering input and community level, kind of listening sessioning level of engagement. And then all the way up through like paid family partnerships and connecting with them, as, really thinking of them as peers in the work that we do rather than, a separate council or community, but there's a level of engagement across that spectrum, right? And so I think it's recognizing and identifying, what the state is really looking for. Are they looking to gain input from families in a variety of ways, or are they looking to truly have partners at every table in every conversation and as kind of part of their leadership team? So I think there's tips and strategies and ways to do that at each of those levels that can work really well, but it also kind of depends on their specific goal.
Yeah, that's amazing. That's great. Thank you for sharing that. I think I skipped Jeff and I want to go back to him. Um,
I was just, it was one of the states in your write-up was mentioned the beneficiary advisory councils that,
Hmm.
that Medicaid's required to have. So I think some of the things that Heather, you probably worked on to teach families how to engage and having them feel effective in those beneficiary advisory councils. But maybe also, and I have not seen any data on this, but unless it may be out there somewhere about how often they're convened, who their memberships are. Because like a disability advocacy group is going to really want to be heavily involved in that. And I don't want it to drown out the kids. I want them to, everybody should get their voice. And if they meet twice a year and hear for 50 minutes about what the Medicaid's program is doing and they take questions, that's not the same as a true interaction. So I'm just curious if, it may be a place to focus because those things require like Medicaid leadership to pay attention.
Yeah, that's a great point. For those on the call that engage with families, I'm thinking about the closed loop part. Do you gather this information from families, pay them for their time, meet when it's convenient for them, ensure that they have a good understanding of what you want to talk about? But then, and maybe Shonda, this is for you. Do you hear then back what's happened with that information and that closed loop piece, and how critical is that piece for family engagement and to continue that relationship?
We meet with our family advisory monthly, at least. And then in between there, we do have some sub work groups that happen. And it is super important to do the closed loop because it gives efficacy to their input. And it also, gives them the opportunity to say, I matter. I matter to this piece, and I will show up again because my voice was heard and it impacted change. And I think that fostering that for family engagement is pinnacle to keep them around, and to keep them engaged. It also provides that measure of for the social construct of we can do, big hard things, and it even at the smallest level, your voice matters. So I think that that's a really good point, and offering the closed loop model as often as you can and being as transparent with that information as well is vital to the sustainability of families engaging.
Yeah, that's great. Yeah, Christina, and being transparent about what can and cannot be done. Yeah, that seems important as well.
And there are times when it doesn't go well. There are times when we have to come back and say, hey, this, we did share what you said and with this level, and this is how it went. And unfortunately, how do you feel about trying again, either whether it's legislation or something of that matter next year? Do you feel like this was a good use of effort? And then also adding their input into that as well, so that they are understanding the process as we go along too. And I'm sorry, Heather, I apologize. I didn't mean to speak over you.
You said everything I was thinking and was going to try to say, but probably much more eloquently. So no, I'll just say at this point, ditto, because that was what I was coming on to say, is that it's actually just as important to explain what can't be done and why it can't be done. Not just that it can't be done, but why can't it be done and how can you overcome whatever that hurdle might have been, and working with them to find that solution, because I think that's something we heard often was, in feedback as we were developing the toolkit, but also just in the work that we did with families, was when I feel like my voice wasn't valued or my voice wasn't, documented or somehow contributed to a solution or an action, I felt like it didn't matter and I wasn't going to give my feedback the next time.
Yeah, that's really important. I can see where families, even if they were paid, even if it was a meeting that was convenient in their schedule, even if it was something they were passionate about, if they didn't get that, here's what happened and here's why, it can deter them from wanting to do it again. So that's great, great feedback. I want to pause really quick here and turn to my team and ask them if they have any questions for you all about family engagement. do's, don'ts, lessons learned, um, even the relationship building between Title V and Medicaid. I kind of gleaned over my own team. Do you all have any questions for the advisory panel? Okay, hearing none and seeing none. I'd like to try to maybe squeeze one more question in for you guys. Let me share my screen again. Okay, let's talk about New Mexico. Brina, I know you've been engaging with our TA teams in New Mexico. Um, just wanting to know, how is that going? Do we have any suggestions for New Mexico? Um, and I don't know, Divya, if I don't mean to put you on the spot, if we want to talk a little bit more about what's going on in New Mexico and their mapping of the systems facilities and their prenatal and postpartum services that they're trying to map out. If we want to talk more about that.
Yeah, maybe I could just give a quick update on where things stand, because we have a bit of an update as of a couple weeks ago. So our team, the CMMP team, had a really interesting meeting with the New Mexico team where they brought to us the preliminary results of an analysis that they've been doing, trying to map geographically using birth certificate data, like where births are occurring, in what kinds of facilities, and like geographically where in the state. Um, and I think that was a really interesting start to a conversation around how can that analysis sort of inform shared priorities for their Title V and their Medicaid offices. So that analysis is coming out of Title V. But they had their Medicaid point person for our CMMP work group was on the call, and she had sort of talked about being really interested in entry to prenatal care specifically and how difficult that can be for the populations that New Mexico's Medicaid agency serves. That people are getting like not updated lists of providers. A lot of those providers are not taking new patients. It can take a really long time. It can be really difficult for folks to get into prenatal care. And we talked a little bit about midwives in New Mexico, like leveraging midwives as a way to like help folks get into care. So that's kind of an ongoing conversation that's happening there. But New Mexico has also sort of done this interesting thing where I think they've not yet really decided on what their shared priorities are, honestly, between Title V and Medicaid, in terms of like what they want to work on together as part of the CMMP. So we've asked their two leads, their Title V and Medicaid leads participating in CMMP, to like sit in a room together in early January and really just sort of go back to the drawing board and hammer that out. What are we trying to accomplish together? We've got all these really cool analyses going. We're asking each other all these great questions, but like, what is that building to what end are we having these conversations? So that's where we're at right now. Let me ask, I see Hendy's on page. I think Liz is here too. Andrea, anything you all would add?
I think you captured it really well, Divya. I think what has become clear to us is that the place that we thought New Mexico was when we started is further, we thought they were further along in the Medicaid Title V having conversations with each other than they actually were. And so I think we needed to hit the reset button. And that was, I think it was, we had a really good observation from Liz, who's on our team from CHCS, who was like, why don't we see if the Medicaid person and the Title V person want to just have a meeting together? Because up until a week ago, we had never met the person who was newly assigned to be the Medicaid representative on the team. And it was clear to us that she was probably not even fully aware of what the role of CMMP is meant to be. So we wanted to encourage those two folks to just give themselves an hour to sit down together and have a sort of shared conversation about those aligned priorities. And so we're cautiously optimistic, I think, that now that we sort of have a better finger on the pulse of where they are at, we will be able to help them in moving along the sort of this kind of continuum, right? And so we may not get where we thought we were going to get by the end, but I think we will certainly, we're starting from a better place now, and now we know where they were. And that means we know what next steps might need to be in order for them to progress.
Wonderful. Thank you, guys. That was a great overview. Jamie.
Yeah, I'm sure you all know this, but the New Mexico Medicaid director recently resigned. Her last day was, I think, last week. And the interim director is Alana Dancis, who was the CMO for the Medicaid program prior to moving into this interim director slot. And I think there's a fair bit of speculation that she'll be permanently appointed into the position. I just think there's an opportunity even to just sort of level set with Dr. Dancis around the project, but also to gain her endorsement, going back to that conversation about how it's super important to have leaders, kind of pushing the team. I think, knowing Alana, she's fantastic. And I know that these issues are important to her. I think it would be just an opportunity to garner some support and have her kind of pass that on to the team within the Medicaid program.
That's great. Thank you, Jamie.
I think the only thing I would add that we had fun talking about with the internal team is that slowdown of sitting, I would encourage, well, it could be relational where they just drink coffee and, get to know each other, but there are certain sort of key elements to a state system that might be lost on each other. And one of the things that we talked about with Hendy and Divya was that there's perinatal quality collaborative, because they went straight to access. The group was really concerned appropriately about how could they maybe use a workforce like midwives to get into some rural parts of New Mexico, and they were like down at the end of the project instead of the how that would fit into maybe the existing priorities of other aspects of the system. So I love that the whole thing's slowing down a little bit because it would be a little silly to. I mean, New Mexico's bigger state than Vermont, but we often find out like 6 months hence that a whole group has formed something that already existed. So it's just, there's so much about this work that's about relationships. It's fun to hear it keep circling back.
Brina, we loved your idea of like relationship mapping, like doing that step of like who else are we aware of that is doing relevant work in our state and are we connected to them and how? Um, and I think we're just not there yet. So I think we're on the same page. I think slowing down, having these two key folks talk to one another in early January is like a necessary step, but it's still on our minds that that's another next step that we should be thinking about.
Awesome. Thank you. I think we only have about 10 minutes left with each other. I think what I would love to do is maybe just put in the back of your minds a couple of questions that we'll want to go over the next time we meet, which the cadence, I think, Sam, if I'm right, would have us meeting again in March. But thinking about where we are, and what the key messages are for Title V and Medicaid. And as we see some of these changes in 2026 and the next 5 to 10 years come through, what are the things that we should be anticipating as the CMMP? What should we be thinking about now so that we can think about ways to partner early, that we can align what resources, events, key messages should we really start to be focused on as the center as we work through year 2, but then to try to help our partners navigate through the next several years. I don't mean for any answers right away. If anybody has some things that they've been thinking about that they believe and want the center to know about and want to be thinking about, um, that would be amazing. But I do want to have this kind of forward thinking conversation the next time we meet on um, one, introducing you guys to the next set of cohort states that we have since the application is due in January. But two, thinking about this and anticipating what are the next things. What do we want to do next? Um, Let me share my screen again. I think we can go on to the next slide here. So with that, just wondering if you all, and I don't know if my screen shared, it doesn't look like it. Just wondering whether or not any of you have any resources that you're working on, resources that you know of. Heather, thanks so much for throwing the toolkit from Kansas in the chat. That's amazing. But any resources you all have that you would like our team to look at, our team to kind of pursue that you think may be helpful in the context of where our states are, at the moment. Feel free to drop them in the chat. Feel free to email them to us afterwards. Anything we can get our hands on that will help these states in the place where they are would be amazing. And then I think the last question here is you heard Brina talk about working with our TA providers with New Mexico. If there are any of these areas in which you all feel you would like to support a connection or you would like to support that state in some way, please reach out. We would love to have you in, a meeting or two with the state partners to help move their goals and meet their objectives. So if there's anything that you saw in the reading material where you thought, hey, I have gone through this. Here's what I've learned. Here's what I've learned not to do. I think it would be great to bring to be at the next meeting. We would love to have you. That would be wonderful. Helen, I think I'll turn it to you if you have anything to add, anything more. I know we need and want to do our polling question for the team,
Yeah.
but
No, nothing more to add. I think let's go ahead and let's launch the poll. As you know, it's the same structure as before, but these questions do really help us, and I hopefully you all can tell that this really was a different approach from previous meetings, really trying to focus on the discourse, getting some examples, and I think it's been really helpful to hear directly from you and even the exactly that, the resources shared. I think we'll, take a look at a deeper look at what the link you put in the chat, Heather, work through some of these examples or some of the tips put here and continue on this path and reflection. But your feedback on how this one will be really helpful. As always, we will be following up, and there'll be another survey with some more sort of open text options to provide some more feedback if you'd like to that way as well. It's really just a way for us to continue to kind of refine the way we work together. But we can continue to refine these meetings as long as we continue to get feedback from you all. That's really the way that we really the only way we can improve them. So it's helpful to have responses. So we'll leave this up as we go. Sam did go ahead and throw the next meeting date into the chat, just so you all can know that. It will be on March 3rd in 2026. It is going to come before we even know it, but it will be, Tuesday, same time in beginning of March. So we're definitely looking forward to it. We'll leave this poll up, but we'll just go ahead and click the we'll send a follow-up email that has a link to a longer survey if you want to give more qualitative feedback to us. And then really just thank you for your time. Thank you for the feedback shared today. And really, it's already year 2, and we're grateful for your continued participation in this.